All right. Thank you everyone for coming here. And today is Health Talk at Sally Glassa. It's a monthly conversation with healthcare providers that is based on topics that are of interest to the community. And the whole point of having these conversations is to really give an opportunity for people to learn about specific health-related subjects from healthcare providers. This month, the talk is on the heart because we happen to be in February. And guess who I have with me? A heart doctor. So Dr. Kelly is a cardiologist and he works for Northside Cardiovascular. And I'm going to ask him to tell us about his practice and a little bit about his bio, and then I'll introduce myself in just 1 second. So Dr. Kelly, thanks for coming. And if you could just tell us a short, brief bio on yourself and what you do.
It's a pleasure to be here. Thank you very much. I've been here for 24 years, came to this country and did all my schooling here, like Morehouse, Emory, and Grady, and all the Emory Hospital and the VA hospital. So I've been definitely Georgia trained. I tell people I'm Atlanta raised, Grady trained. So I've been here for over 20 years. I work for Northside Heart Institute, and my practice is in Lawrenceville, next to the hospital, also in Snailville, right close to your practice. So, and I do mostly focus on general cardiology, focusing on preventing heart disease. That's my main focus right now, but also treating heart disease and preventing any worsening outcome of these current heart disease the patient have. And I do a lot of underserved work in the community too, because that's what I came from. So that's why you pretty much joined medicine to prevent heart disease technically.
Excellent. That's awesome. So, we heard about Dr. Kelly. So Sally Glassa Direct Primary Care, where this webinar is being recorded at, is a clinic that is a subscription-based primary care clinic. And I happen to be the medical director for Sally Glassa Direct Primary Care, and the main reason we exist is to really be able to provide an enhanced care by way of giving care when needed. We offer same-day appointments to patients, and we also provide lengthy as needed contact time with patients, which is something you don't get on the traditional medical side. And to that end, we're relatively new. I moved from Baltimore, Maryland, new here, but we're creating connections with people like Dr. Kelly, who, by virtue of the fact that I'm an internist, when a patient comes to me who has heart disease and may need cardiac issues, then I will have people like Dr. Kelly to send to. If I have patients who come in with, to see me and they have medical conditions that are out of the scope of internal medicine, then we have a resource of specialists to whom we're going to refer to. So we are a primary care clinic that is concierge model. We do work a lot with the area subspecialists for the purposes of medical needs that are out of the scope of practice of internal medicine. So I'm an internist and Dr. Kelly is a cardiologist. So let's jump on to a few questions that I have for Dr. Kelly. We'll sort of bounce thoughts and ideas off of each other. As an internist, I do see a huge number of cardiac-related medical issues. And then Dr. Kelly, of course, sees primarily cardiac-related patients. So when people talk about cardiovascular disease or heart disease, the first thought that comes to mind for a lot of people is heart attack. And cardiac disease being the most common reason why Americans die or have medical morbidities, we ought to talk about what else is there when we talk about cardiac disease besides the fact that someone says, I have a chest pain and I'm going to have a heart attack. So if you could just tell us a little bit about the different types of cardiac disease that you see.
That's a great question. I mean, I think now heart disease is the number one cause of death across the whole world. It used to be infectious disease for some time, but now I think because of the Western diet and and the decreased mobility of just human in general. We're just having more and more heart disease across the whole world now. But cardiology is a very broad specialty. We deal with a lot of things. There's also the prevention part of it, where we actually meet people like who don't have heart disease, or have risk of heart disease, and we risk stratify them, work with them on decreasing risk of having heart attack or a heart disease. So that's part of it. That's what I focus on primarily. There's people who have like heart attack or had a heart attack, and they come to the hospital and they have to get a stent or get a procedure to, take out their blockages, and so they could have perfusion to their heart, and they feel better. That's one part of it. That's what usually interventional people do, like where they do stents and different procedure. And then you have also a specialty of heart failure, when people have weak heart. That could be from high blood pressure, from blockages of heart vessel. That's also a very common trend now we see. A lot of people are suffering from that. So, and then on a big part of cardiology also having rhythm issue. The heart is pretty much a muscle with vessel supply and electricity. So if you think about each of those things could cause a problem. So there's also rhythm issue, very common rhythm that people know about, atrial fibrillation, which is something a lot of people suffer from. So that's something we treat too. And then also you have the valves, which I tell people the valves, in your heart, like the doors in your house. So they end up not working, and we have to fix them too. So if you think about it, like the heart is just like, you think of the heart of just a house, has electricity, has an engine, has doors, has spaces in there, and those things, something could go wrong with it. And for each of them, you have a specialty in cardiology. My job is, most of the time, is I'm seeing these patients and I'm like, okay, well, you need to see an electrophysiologist to take care of the AFib. So I refer them to that. So I'm technically almost like a primary care doctor for cardiology. I see these patients and I triage them if they need a procedure or some intervention to be done. And I take care of the basic stuff that needs to be taken care of before they end up in a very complicated state.
That's awesome. I love the way you described the heart as a house, and it has a door, it has electricity. It's a cool organ. It happens to be one of my favorite organs.
Mine too.
Well, go figure, right? But yeah, so with common heart diseases, the coronary disease, the valvular disease, the arrhythmias, and then, obviously congenital diseases, right? Yes. People are born with certain heart diseases, those occur. So it's really important to keep in mind that it's not just that somebody has a blockage in their arteries, there are also other things that was just as mentioned. So going from the bigger picture of different heart diseases, what are some of the common symptoms that people come with when they have heart disease? What do you typically see patients for?
And it's a great question. Everyone presents a little differently, but the common thing, chest pain, and again, chest discomfort, chest pain, chest sensation. If you are, someone who has some risk factors or a family history, and you're having some chest discomfort, especially when you're exercising or exerting yourself, you should definitely go see a primary care, see a cardiologist, and make sure you get that screening for. And, shortness of breath, fatigue, getting weaker with time, that's also something to pay attention. But also, like now that we have more understanding of, heart disease in women do present sometimes differently. Like, they might have different symptoms from man. The chest pain might not be the typical chest pain that a man, like people think of, like, oh, my chest hurts and I sit down, it gets better. A diabetic patient presents differently because of the neuropathy and all of this. So, but I'm saying, like, the heart just, the way you should look at your body and the heart, just the way you drive your car. You know your car very well. When the engine is not doing its job, you're gonna take it to the mechanic. So you know it, like you're pushing the gas, things are not moving well. And you start thinking, okay, something's wrong with my engine. The heart is the same thing. It's very good at telling you there's something wrong with it. And if you keep ignoring it, at one point it's gonna fail. And that usually either end up being a heart attack or a heart failure, or unfortunately, worst case scenario is death. Because when the heart stops, you have no perfusion to the brain, and if so I'm saying, like, the heart is very good at telling us there's something wrong with it. Just like your car, tell people, like, it's very good at telling you a signal, and you need to pay attention to your body.
That's really, really good. Now you bring a very important pivot point, which is the intricacy of figuring out what is your heart and what's not. So as an internist, some of the things that I see all the time is people will say, I have chest pain. Yeah. So, and it's up to me to figure out, is this costochondritis? Is it GERD? Is it musculoskeletal? Or is it really your heart? Or is it panic attack? So there's so many potential causes for chest pain. So it's upon us to sort of tease out what really is, quote, your heart and what's not. And I think what Dr. Kelly just mentioned is worth kind of going deeper into is we have the set of people, women, that tend to come with a slightly different way than men. And a lot of times because of that difference, a lot of women get less attention about cardiac disease and end up being diagnosed at a much more stronger or serious situation because we don't pay attention to the difference. Can you say a little more about how heart disease in women presents differently from men?
There's all the symptoms. The symptoms are sometimes women present with chest pain that is more like central, sometimes it's not in a typical area, sometimes it's not as that nagging, pressuring pain. It could be sometimes sharp. But very important aspect is, the two things that always make me worry about a patient is age. An 18 years old having chest pain is not the same thing as someone's 50 years old. An 18-year-old having chest pain, I'm not worrying about heart attack right now, maybe something else. A 50-year-old having chest pain, that's more concerning. So age plays a big role. Your vessels in your heart are your pipes in your house. If you call a plumber, if you just bought a brand new home, you're not gonna have a plumbing issue. 50 years down the street, you're gonna have. So that's what I'm saying. Think about your heart as like age is very important. And the second thing, family history. I have had friends who their father died at the age of 40 from a heart attack, and they call me, I'm having chest pain. I'm like, go to the emergency room. I'm like, you're 45. Your family history plays a big role in this. So like if your father or your mom or the brother had heart disease early age, you're most likely gonna develop some of those things if you're not taking care of yourself. So that's family history. And then with women, you just have to, again, it's very hard for internal medicine because chest pain is the number one common symptom presentation in the emergency room. So I think EKG is definitely one thing, make sure the patient isn't having a heart attack right now. Other thing is symptoms. Symptoms plays a big role. Like if the chest pain is getting worse, not getting better, it does not look like, a flu infection right now, does not look like it's reflux. Better be on the safe side to send them to somewhere, so. Yeah. But age, family history plays a big, important aspect of this. That's the easy way to look at it. Of course, if you have diabetes, high cholesterol, high blood pressure, that's also a big part of it. So, but to make it easier, if you're aging, then maybe if you have chest pain, get it checked out. If your family history, they have heart disease at early stages, you should definitely get it checked out. Because if your father had a heart attack age of 60, he developed heart disease in their 50s and start getting worse. If you had a heart attack in your 50s, you'll probably be developing heart disease in your 40s. So you should get screened much earlier than what your parents developed. So.
That's excellent. Yeah, so I think the tricky thing, as you said, is especially for the general population, people may not feel like, well, maybe it's okay, maybe it's not, maybe it's really something I ate, so there's a lot of questioning, and it's reasonable to question because there are so many different ways that people may present for various things other than the heart. But it's better not to take chances, I think, is what I'm hearing from you, especially if you have family history or if you have risk factors or if you're someone who has, if you're advanced age, if you're a man above the age of 45 or a woman above the age of 50 or postmenopausal, which also I think is worth mentioning that before we hit menopause, women have less risk of cardiac disease. But if you look at the graph of incidence for heart disease, as we start going into that menopause age, then I think the graph begins to approximate together. So when you're in your 30s, a woman is less likely to be at risk, right? Then when we hit that menopause, we have exact same thing. And I think adding to the fact that women present with even less common presentation, it's absolutely critical, I think, for women not to ignore chest pain. Because we have symptoms that are not typical, and also our risk begins to approximate men's as we get to be in that kind of older age group. And I wanted to just ask something that I came across not too long ago. I don't know if you see this regularly in your practice, but I read somewhere that up to 65% of women who present to the cardiac center to get catheterization, which is when they send a catheter up either through the radial artery or the femoral to look at the vessels of the heart to see if there's any kind of blockage. So up to 65% of women who may not have obstruction in their vessels may have this so-called subobstructive cardiac disease, which adds to another layer of women presenting differently. Do you see, I know you're not interventional cardiologist, but how often in your practice do you see women who may have non-clinical obstructive cardiac disease but still have symptoms?
Yeah, I think what we're talking about is microvascular disease. That this is a vessel also, the heart has the major vessel. That's what we look for and make sure they're not blocked, because these are the main pipes that supplying your whole heart muscle. But it's also the very small one, they come out in the branches, and those you cannot really stand sometimes. They're too small to even go. They sometimes have some blockage or a spasm in them. So there's treatment for that. We give a medication to relieve some of those, spasm or to help out with this. But that, subset of that is small and is more common in women than men. And it is hard to treat sometimes because you don't know if this is the heart or something else. So there's pathway for us to usually with medication to figure out if this is helping or not. But the good thing is usually those people do not have major blockages that needs to be fixed.
Mm-hmm. Okay. Yeah, so then there is the spasm issue in addition to other non-clinically significant blockage that may cause heart disease. So you work in prevention. Tell us a little bit about your approach to talking to your patients when they come to you for cardiac prevention. First of all, what kind of patients come to you?
I mean, most of the time, patient who has family history of people had heart disease, they don't get a checkup, or someone who just sat down somewhere and heard a friend who's their same age died from a heart attack or have heart failure. So that's kind of what a lot of my patients come with. And all depend on each person's different. If the person's exercising 5 times a week, has no symptom, this is a pretty healthy patient who's taking care of himself. But between the age of 40 and 65, we have this method called a CT calcium score, which is a calcification of your vessel. And the way you can look at it is rusting of your pipes in your house. So doesn't mean you have blockages, but you just have very early issues going on with your heart vessel. And that's what I think it helps people to say, okay, I have early signs of heart disease in my vessel. I don't have significant blockages because I'm feeling good. What do I need to do about it, and how do I fix these things? And the easy thing is usually we recommend an aspirin for these people who have some calcification. We do address the cholesterol more aggressively because your cholesterol panel only tells you what a normal person cholesterol should be. When you have early calcification of your heart vessel or early heart disease, that number doesn't matter to you. You have a much lower target then. So cholesterol is the main foundation of heart disease. That's the building block that builds those plaque and the blockages. So it's big. If you cannot control it with diet, you definitely need to take medication. I tell you a story. My mom, all her brother had heart attack in their 40s and 50s. She is 62, start taking statin in her 40s, and her calcium score is 0. So the medicine did definitely make a difference in her. So, and very careful going online reading about these medications. It's just like me going reading about transmission in a car and not understanding mechanics. So I'm gonna say, why do we need transmission? I don't understand cars. Same thing with medicine. You've got to have the context of understanding the whole big picture for something to make sense to you. So it's very dangerous when people come to me, I don't want to take this medication. So I think that's very important at prevention. Know what your calcium score is. That's a very important number. Your primary care could order it, a cardiologist could order it. You don't need a specialist. If it's elevating to see a cardiologist, work with your primary care and your heart doctor on lowering the risk, like cholesterol being one. And then the most important thing is weight, I mean, if you have extra weight, it's not going to go away with age. It's just going to get more and more. And fortunately, we live in a society that food is very affordable and available. And I love food, and I know weight loss is very hard. It's one of the hardest things because So weight will eventually the weight around your waist is going to turn into diabetes, high blood pressure, and high cholesterol. It's just building up to get there. And it's very important to think of this. I tell my patient, if you lose the weight, I take off your blood pressure medicine if you control it. So weight is a big predictor of this. It is hard to lose weight. I know that. It is. Before, as doctor, we tell patient, here's a pamphlet, go exercise and diet. If it was easy, all of us doctor will be very skinny. So, but right now we have methods to lose weight. There are drugs out there in the market that help you lose weight if you cannot lose weight. It's very hard for my mom, she was menopausal with her hormonal changes, having thyroid disease, to even exercise and diet. So we had to get her some medication regimen with the primary care to lose, because that weight will eventually cause diabetes, high blood pressure, high cholesterol, will lead to heart disease. And think of longevity. People live until 90 to 100 years old now. You don't have to believe me. Go into your churches and supermarket and see anyone above age of 90s. Guess what? They are on the thinner side. You don't meet many obese people who live past 80s and 90 years old. So weight is a very good. So when I have a conversation with my patient, I'm not talking about heart disease. I'm like, you want to live long enough to see your grandkids and their great grandkids, which is possible now when you turn 100. You got to lose that weight by any means possible. We have to figure out a way to lose this weight. So and that's my long answer for this. So a lot of the time, I'm actually having conversations with my patient about how to prevent heart disease, how to lower the risk factor, and how to find meaningful way to reach those things.
Right. No, that's excellent, and that's really well put. And it's sort of the core of internal medicine work is balancing act of teaching people how to reduce risk so they don't have to come see you, right? Or your colleagues who do intervention on them. So one of the things we do here is we calculate the risk of developing heart disease in clinics. So the AHA and ACA has created risk calculation methods. It used to be ASCVD, now it's the PREVENT. So what we do now in clinic is regularly I actually calculate that for anybody above the age of 30. I put in their information on the PREVENT calculator because the ACA has the PREVENT calculator online for you. I put their cholesterol, their age, their systolic, diastolic blood pressure, and then I put in, I think, the PREVENT has started putting the EGFR, the basically the efficiency with which your kidney is filtering. I put all of that in, and I get a number, and based on that number, if it's intermediate, then I say, okay, we really need to talk about you having to be put on a medication, because for a lot of people, as you were alluding to, there is a lot of concern about taking medication, especially if someone is taking 4 or 5 medication, you try to add another one. That is not okay with some patients. So for me, one of the things about working in direct primary care, where I have an hour, is I have this long period of time where I'm able to engage with patients, show them how I calculated this risk factor, and tell them what to do. So risk stratification is a key part of the management that I think we both share in terms of making people understand it is the leading cause of death in the United States, and here is your risk. And then the next part is what can you do about it? So this is something that we do on a regular basis, so I'm really happy you're talking about this. We do have a few questions that are come up, but we'll wait on the questions if that's okay. Let's touch on, if you don't mind, about some of the non-traditional risk factors that you see. For example, well, first of all, let me go back and just say, if you don't mind, just for the basics of it, if you would just describe the traditional risk factors, and then the additional risk factors that are coming up now we're beginning to hear about is social isolation, stress. These are things that are now becoming more common in the regular conversation for risk for cardiac disease. So if you just walk us through that, that'd be great.
No, and that's a great question. I think we touched on some of them. Like, the major one, I mean, there's some things you could change, some you can. I mean, some of the risk factor being, age. You can't reverse aging. So that's something that you got to have to, deal with it, as you age, just be more mindful of it. The common one, like obesity is another one. So like that's a big one. It used to be smoking. Fortunately, we have less people smoking, so it's becoming less of an issue now. I think with the young people, it's more like the vaping, all that. I don't think in 10 years we'll find out how this is going to be so bad for the population. Just like when smoking started, everyone thought it was a great idea to smoke. So I think that's another thing, any kind of smoking. And then, the diabetes, high blood pressure, high cholesterol, those things, that adds together to the traditional risk factors. But the non-traditional one, I think they are technically traditional. I mean, stress, is a big one. I mean, if you're stressed out, most people end up not following these guidelines to take care of their body. I mean, if you're stressed out constantly, you're really not going to the gym and exercising and eating the way you're supposed to. So stress affects all of those other risk factors. And then isolation too. I think there was a data shows like over 20% of Americans are lonely. They don't have nobody live with them, nobody checks on them. So that's the thing. Definitely affects your risk, and also probably increase inflammation in your body, which adds to increased risk of heart disease. So, but I think that those are great things. But the big ones are the common things we know, very well, and that's what you deal with most of the time, in your practice too. So
yeah. So yeah, just for educational purposes for
and
people
who may
read this.
too.
Please say
yeah,
more.
sleep is a big issue. I think with the rise of all these energy drinks and especially with children, I see that a lot. So like in kids, so that's a big one. I think based on your age range, I think you just have to figure out what is good amount of sleep for you. I think in this country we really underestimate the power of sleep, and I see more of it now. People learning about it. So having a good night's sleep makes a huge difference. I mean, that's why the shift workers, actually there's been study done, night workers actually have way higher risk of all kind of chronic diseases compared to like day workers. I think it's because their sleep cycle is so off. So.
Is there anything, is there good research to show, or is this the catecholamines that get jacked up all the time?
I think exactly. It's a steroid cycle, a circadian cycle. I mean, it's just a human not meant to be awake at night, so like for long periods. So, but again, some people get used to it, but it's been shown. I mean, good night's sleep really helps with building your muscle, and decrease inflammation, and all of those other risk factors.
Yeah. So I think that the take-home message is, I don't think it can be overstated. Cholesterol, obesity, hypertension, diabetes, smoking, age, family history, these are quote unquote the traditional ones. But then I think what we're talking about is, and I'm glad you said this, I guess it's not new, but we're becoming more and more aware about, what is it about stress? What is it about lack of sleep? What is it about social isolation? I find this extremely interesting because we've sort of come into a lifestyle in the Western society where these things are, as you said, actually the Surgeon General said the number one public health problem in the United States is loneliness. It's not cancer, it's not diabetes, it's loneliness. And it's because we're beginning to understand the domino effect of what it is doing to the cardiovascular system and to the rest of the body, to your immunity. So these are critical things, and I think there's a question actually that had come up about sleep and cardiac disease, but my understanding is, correct me if I'm wrong, some of it is related, the change in the circadian rhythm, but also catecholamines, right? Cortisol level goes up. Cortisol is the body's endogenous sugar, which could be actually pro-inflammatory for the coronary diseases and the rest of the body. So I think a lot of research probably is up and coming, but it'd be really interesting to see what kind of intervention we could come up with for loneliness and isolation and all these social determinants of health that actually feed into this problem.
Yeah, I mean, sleep is so important. Like that's one of the 4 essentials to live. I mean, you need oxygen to live. If you don't get oxygen, you're obviously not going to be living. Food and drink, you can sustain yourself. But the funny thing is, all these other three, you could prevent yourself from getting it. But sleep is one of the things your brain will shut down. Like you eventually cannot make your brain not sleep. At one period of time, no matter how much caffeine you drink, your brain will fall asleep. So I mean, that's what happened to a lot of people who work like extended hours and driving their car. No matter what they're doing, is they just, because your brain will not let you not sleep. So that's how important sleep is to your body too. So just keep that in mind.
Mm-hmm. Absolutely. Well, sometimes you can't sleep well. So what do you do?
Well,
that's a hard one.
Telling a newborn kid or the mother is hard. I think also.
Do you have a newborn?
I had two, like, but I mean, I think what we need also, in addition to stress, I think we forget the concept of resilience. I think that concept in America is still rising. Like, I mean, we wonder what certain country under war zones still feeling good and doing it with their life while we like get stressed out about everything else. I think the concept of resilience is very important, that we need to learn that. I tell my patients sometimes when they come to me, I'm like, I feel depressed, I lost my job. And I'm like, okay, well, that's normal behavior. Like, you're feeling bad about losing your job, but you got to go through this pain. You'll learn better. I think we think that certain emotions are bad for us, but it is. If you lose a family member, you're going to feel depressed. That's not a pathology. That's a normal behavior. And that creates resilience eventually, which actually helps people fight chronic diseases too. So I think that concept is, stress exists for a reason too, to make us tougher. I don't like that thing, what doesn't kill you make you, I don't believe in that. I think this is the old school mentality. I feel like, and I don't believe in that. It's just like some middle ground of that helps,
And this might be, and we'll open the up for discussion in a minute. But I think because this area is so interesting to me, the whole idea of stress and its effect on heart and everything else, but also how do you combat that? I think you brought up a very important point, which is there are parts of the world where they have so much less than we do in the United States, and the adversities are astronomically higher than here. But people seem to find joy in life in some ways, and there is like maybe it is resilience. Maybe it's also having a sense of humor or some sort of way of kind of absorbing some of that. And I think it would be really interesting to see if we could, in modern life, create some sort of resiliency or some sort of a shock absorber for stress.
I mean, it goes back to the loneliness. I mean, I feel disheartened when I have a patient in the hospital and nobody visits them. You could see it. The people who have all these visitors coming to their home or having their cards sent from the church or flowers, those people do have better outcome. I see it like they have better follow-up, they have better family connection. And I think there was a study done, like they took 2 stage 4 cancer population, they gave them both the same treatments, and the one that lived longer and had better outcome is the one that had a positive outlook. They had the same treatment, same cancer, but they actually did better because they thought of this, I'm going to make it through this. They had a better family support, they had a positive, nothing changed in their treatment, but they did better. So I think does that play, human is not just like, bone, muscles, and vessels. There's more into it that we don't understand. I think the mind plays a big role in this. I just happen to be a heart doctor, so I just deal with it.
No, that's right on. I remember that study. I think it actually was done at Duke.
Yeah.
And they actually had people pray for people.
Yes.
So it's really incredible. Now, whether you're religious or not, or whatever your conviction is, the point I think that I'm hearing, and I remember learning about this in medical school, is there is something that happens to us inside when we feel connected, cared for, and loved. So that part cannot be overstated. These people were cancer patients, and they randomized them, and they found that it actually makes a difference. So it's just understanding that we have a lot of stuff that we've not kind of ventured out into that potentially might be helpful for us to stay healthy. So I'm getting a notice from Jeannie. There's 10 minutes left, so I need to hurry up to questions. Sure. So we have a few questions, and I will go through them in the order they show up on my computer, on my laptop, on my phone. If there is a small blockage, what can you do in your heart vessel, that is, to unblock it without medication?
Well, Yeah, that's a good question. You cannot reverse blockages because I know I see online all these things like take this pill and your vessel's clean. Well, obviously Drano doesn't work for piping, so I don't think they're finding
There is no
one for.
Drano?
Well, they haven't found the one for like my home, so I bet you they haven't found one. If it was, I would use it for my patient, but it's not. So because remember these are calcified vessel, and then what it builds up is that plaque that builds up, and over time, so it becomes hardened. The way we fix that when we do a stent, we push it out, and the stent becomes part of the vessel. So small blockages all depend what it is. If it's a very small vessel, they don't touch it, they treat it medically, so it doesn't get worse. So it's a hard concept to understand that, but usually we focus on the main vessels, and a very small one we treat it medically. But there's really no treatment of these vitamins that people take to reverse it. And I'd be very careful taking these blood thinner vitamins because they could affect your other drugs. So I wouldn't just go mess around. I mean, again, my friends always send me this TikTok or a YouTube video of saying like, oh, they fixed the heart vessel. I'm like, great, well, I'm just gonna quit my job then. Because everyone just take, and obviously there's plumbers in the world, there's gonna be cardiologists. So like, I'm just saying like, it's not that easy. The body is not that very simple. There's more to it than just like taking one pill fix it all. So.
Cool. So there's no Q10, garlic, or anything that would unblock it.
Wow, funny story about garlic. My cousin kept taking garlic for preventing heart disease, but he couldn't find a wife. And then I told him maybe you should stop taking garlic. And you have a better risk factor not being alone. So I was like, you're gonna be lonely all your life taking this fresh garlic. So
he's gonna live long though.
that's what I'm saying. Like you're gonna be lonely and
lonely.
Yeah. So maybe when he stopped the garlic, he's married. So now, so finally.
Oh shoot. Okay. Well, you know how it is. Right? Life is, gives you one thing, takes something else. All right. So, is there a level of cholesterol level that is that a healthy diet cannot fix?
So yeah, that's a great question. A lot of people actually have something called familial hyperlipidemia, and this is usually, oh, mom or a grandfather had a heart attack in their 50s. That tells me they had probably some early cholesterol buildup. So your body's not clearing cholesterol well. So that's those cases you need to see a cardiologist or an endocrinologist, one of those two specialties that manages. And we have actually amazing drug for those. Even though the pill doesn't work, we have injectable that will lower your cholesterol tremendously. Because if you have high cholesterol at a young age, that's just gonna build up in your vessel. So if you start having high cholesterol at 30s, if you don't treat it, you're gonna have a heart attack by 40 with the blockages. So it's very important to treat cholesterol. So that's a great question. Sometimes medicine doesn't work, the pills, sometimes even diet doesn't work. That's why we have newer drugs that actually work on those specific patients.
Yeah. Okay. Next question. Should a person at risk consult for heart health before starting to exercise?
Well, if they have symptoms, so I tell my patient, like, if your car's making a noise, you're not going to take a trip to Nashville with it. Because the two things could happen. You could make it, or you could be on the side of the highway waiting for a towing truck. If your heart is making a noise, get it checked out. There's time for exercise. You have the whole lifetime to go in the gym. Because a lot of time when a patient come tell me, oh, I have chest pain, shoulder stuff, like, can I exercise? I'm like, well, hold on. Unless you're an Olympic player, you're going to make money from exercising. Let's just wait for a minute. Let's get the testing done. And if it looks good, you go back to exercise. So to me, it's very important and again, exercise, exertion activity, all kind, like, start cleaning your house randomly. One thing that people ignore also, intimacy. That's an exercise. If you're having chest pain, shoulder, you should hold off on anything that makes your heart race or exercise until you see a specialist. Because that's very important. Like, don't ignore your symptoms. Your heart is very good at telling you what's wrong with it, and it's very good at actually keep telling you this until it fails. So so it's very important to get it checked out and stay. I guess like I tell my patients, you have the whole lifetime to exercise. This is today. Take a break for a couple of weeks until we figure out what's going on.
And don't take Cialis if you have that.
Yes, exactly. So I'm just saying, like, anything that exerts your heart. So.
Yeah. Okay. Is a high level of good cholesterol make the bad cholesterol less great? I think he's talking about the HDL.
Talking about the HDL. There's good data on. So having good cholesterol is a positive, doesn't negate having bad cholesterol. Does that make sense? So having good cholesterol is a positive bonus point. But what I care about most of the time when it comes to cholesterol is the LDL. I tell people, if you don't remember anything from what I tell you today, make sure your LDL is low. I call it the loser cholesterol. easy to remember. So HDL is happy cholesterol. That's not what it
Really
stands
is.
for, but you want more of the happy cholesterol, you want less of the loser cholesterol. So the lower your LDL, the better it is. Back in the days, they didn't know how low you could go because we didn't have the drug to drop it. With the new injection, we discover is the lower it goes, there's no side effect with your body. So the lower you have LDL, the better it is for your vessel, the less blockages will develop. So.
So a related question to that, what does the good cholesterol, the HDL, do for you?
Well, that's a whole lecture about it. But pretty much it just helps with very clearing some of the pathways to create, blockages. So it's kind of like a positive impact of not causing the blockages. But really, the key is I tell people, focus on the bad one more than anything. Now, having an okay HDL or a low HDL is not as bad as having very high LDL. Doesn't that make sense? So your LDL is the one you should focus on. A supplement that helps with cholesterol, people always ask me something that I do now, like I go do research on artificial intelligence, pull up data, and I think one of the supplement that I would take early on is omega-3. So you can get it from all kind of things. It's a great supplement. It prevents cardiovascular disease, has effect on that. And I think that's what the blue zone people are. I don't know if you heard about the people who live beyond 100. And if you notice that they all live on the seaside and probably eating a lot of seafood, which has a lot of omega-3. So that's, I think, very highly correlated with the dementia prevention and all this. So if you start early on, it's good for muscle, exercise and all this. Omega-3, you can get it from anywhere now. And we don't get it enough from seafood. But people tell me I eat salmon. You're not eating salmon every day in the capacity to get it. So, that's a great supplement to take that I recommend,
Yeah. Yeah, just for clarification purposes, because I know I get asked this in clinic.
Yeah.
So when we say LDL, HDL, so it stands for, the L is lipoprotein. So these are lipoproteins that carry different contents and cholesterol. So when we say LDL, low density lipoprotein, and VLDL is the very low density lipoprotein, HDL is high density lipoprotein. So these are lipoproteins that carry the cholesterol. And that's the density, or how big of a cholesterol group, if you would like, that they carry is what they stand for. But I really like to tell my patients, if your HDL is good, then we got something to celebrate, because I think it's really good to celebrate. But
Yes.
I think that the key thing to remember, and what Dr. Kelly is emphasizing, is focus on the bad cholesterol. And I like your loser acronym, or
Easy to know.
naming it, renaming it, and that's the bad cholesterol. So really keeping it as low as you can is really a good idea. This actually brings me to a question I have on myself. So now we're beginning to check. I do this thorough, comprehensive physical exam on patients, and it's for executives typically. And in that executive physical exam, we also check lipoprotein A, which is an independent risk factor for cardiac disease. The problem I have, and I'm wondering if you have more recent data knowledge on this, is what do we do with that information? Do we have anything else up our sleeve for lipoprotein A elevation?
Yeah, I mean, that's an interesting thing, and it's hard to explain what do we do that. I usually, when I check it for people who have normal cholesterol, family history, and they're doing everything right, but they develop maybe some heart disease early on. And why? There's no treatment to lower it, but there are drugs on the market about to come to lower that specific, component of this. But I look at people like you could lower it with data shows diet, exercise, and be on a statin. So there's some data overlapping. If you take those medication and you do the right thing, it does keep it low. So I think I would look at this more of being aggressive. Your cholesterol looks good, but maybe this is not a good target for you. Maybe this is still like your LDL being a 75 is great. Maybe we should focus on lower even more, and that would help with some
Got it.
I look at more of like a target rather just treatment.
Gotcha. Okay. Yeah, that's
Great
good.
question.
Yeah, I think that's very helpful. Okay. Did I miss anything? Did I get all the questions? Okay. Very good. All right. Well, is there any other question from anyone here? Go ahead, Glennis.
You talked about the importance of losing the weight. If somebody can't lose it on their own, they have medication for it. And I see a lot of advertisement for medications like that. What are some of the side effects of it?
That's a great question. Uh, and I'm sure you're talking about those common drugs, the Ozempic and Mounjaro. Those are the big market. They're the only two available right now in the market. So they actually have now cardiovascular benefits. Ozempic does. Like, so if you, and sleep apnea benefit and chronic kidney disease. So they're coming out more learning. But I think it's all related to weight loss. I mean, if you lose weight, everything gets better eventually. So it's very hard to distinguish side effect versus allergy. Like, those drugs make you eat less. So, I mean, the hardest part of diet is hunger, right? We all be skinny if we could control hunger. I mean, this is really what it is. But the drug is very good at telling you, okay, hunger is not a problem anymore. What people don't understand is when you take these drugs, you're probably going to eat 30% of what you've been eating. So if you got to start eating more and forcing yourself, you're going to get nauseated. That's not really the side effect of the drug. That's how the drug works. So people forget that, I'm getting nauseated, I'm getting and then there's different dosing mechanisms. Some people could start a lower dose and lose weight. To me, what I tell my patient is, it is very hard to lose weight. And don't believe me, believe Oprah. She is a billionaire, had 3 nutritionists, bunch of fitness people. She was part of Weight Watcher, left all of that and used Ozempic to lose weight. Just to tell you how much, I mean, she's a very smart billionaire. She took the drug because she realized she needed to lose the weight. So if she did it, and Charles Barkley did it, and all these other, if you look at the Oscar, everyone's very skinny on the Oscar. So they're not suddenly exercising. They're using those drugs. It's a way, people try everything, and if they can't lose, I'm like, we gotta get rid of the weight, because eventually it will become diabetes, high blood pressure, cholesterol, and heart disease. So, and I do believe these drugs are getting better, and they've been studied for 10 years over 40 countries. So they're not and I think America is one of the privileged ones that has some access to it. Not everyone in the world, they have it actually. So again, but you got to talk to your primary care, look at the different conditions. We're now going to start prescribing it in cardiology clinic too, because we're getting those indication of cardiovascular disease too. So we have some of my colleagues start prescribing for the patient, because a lot of my job also is telling patient, you have extra weight, we need to get rid of it. So I mean, it's a conversation that sometimes as a primary care is hard to have when you have 7 medical chronic problem and you have to fill a disability form and some other things. It's very tough. We come in that role too, but hey, I'm your heart doctor. We gotta, we can't keep adding blood pressure medicine here. We gotta do something. But before we didn't have any of those drugs. I mean, there was the drug phentermine, which caused a lot of side effects, and I never prescribed it. But now we have some ways to help the patient. I mean, what do you tell a patient who has knee, osteoarthritis, can't exercise, can't get to a pool? They have now 5 different chronic conditions. There's something we need to do about it. So.
Yeah.
I know what your experience has been with these drugs.
I agree. I think they have been a godsend in many, many ways for a number of people that have struggled with their weight. The only caveat from my perspective is the why. Why do we have obesity epidemic in the United States? Why did we need these drugs to come up? So I wish we have done a little bit more looking into what is fueling the obesity epidemic. Yes, we can fix it. So every single time we have a pharmaceutical fix for every problem. I think as prevention, people who focus on prevention, I really want to know why. Why do we have that? And that's a whole different conversation for a later time. But yes, it's definitely worth getting into those if you struggle and are not able to improve. So we're about to conclude. I see that you got a couple of things. Is that something you wanted to share? You wanted to show?
No, these are just Northside, heart attack signs, and know your number. They have them available. But these things we give to our patients, and we do our marketing so that people are aware of what heart disease look like and what things they need to pay attention to. But it's the same thing we just talked about. It's just a summary of that on cards and magnets. So.
Okay, great. Well, we're stopping, so I'm going to give you a chance to just kind of say if there's anything you want to say, and how do people find you?
Oh yeah, I mean, my last name is Kelli, and I'm part of Northside.
We'll write it over there.
I'm the only person I think in Georgia with the name of Haval as first name, so it means friend in Kurdish. So you put my name and Northside comes up right away. So like I said, I love seeing patients, and again I tell people I'm not the best cardiologist in Georgia. My professors are the trainer, but I take care of everyone where my family is taken care of. So if I sit across from someone, what would I do for my mom? That was my mom in the healthcare system. So that's my standard of care, pretty much. I'm not satisfied with not knowing the answer. I will try my best to figure out the answer. And it might take me some time. Sometimes I might have to ask some other people who have more experience than I do. So, but again, it goes back to we take care of people the way we're a family to be taken care of. That's our standard in our practice. When you come to our clinic, you get welcome just like if you're a family member of one of the physicians or the nurses. So, and we have great staff in the back here and here to support. So, please let us know. Again, Northside is growing in cardiology. Is a one-stop shop now. Like they have heart failure interventionals, electrophysiology, do structural cases. So. We do almost everything that any hospital does in Georgia, and I think with the tower being built now in Lawrenceville, it's going to be one of the biggest in Georgia. So
Yeah,
about
that's
maybe
awesome.
1,000 bed almost,
That's amazing.
Yeah, and it's
That's
going to be a cardiac
amazing.
center, and we're full state of the art. So it's really definitely looking forward to,
That's awesome. So we'll tag him on the video on social media. So if you need a cardiologist, here is one that you've heard from, and I really loved interacting with you, especially because I think we share that same prevention slant on caring for people and in the neighborhood in Snellville. So Dr. Kelly is a wonderful resource for us in this clinic. So we'll definitely tag you and make sure that we pass. If you have your cards, leave with us,
Yes,
and we'll make sure that we'll have that. Before we close, to quickly, Sally Glassa again is a direct primary care. A lot of people don't know what direct primary care is. Direct primary care is subscription-based clinic. It's a primary care clinic just like any other primary care clinic, but we use subscription-based payment rather than insurance. And our patients are adults, 18 and above, and they come for a whole various different issues that ails an adult person. And we have same-day appointment and same day or next day appointment, and our visits are about an hour. So we're here in Snellville, and we would love to see you if you need a primary care doctor. And we are connected with area subspecialists, as we did today. We talked with Dr. Kelly. We have other people that are going to be coming in. Every month we do these talks, and we introduce different practitioners so that people in the community are aware of what resources they have for them for medical care. All right, thank you so much.
Thank you. It was great.
Really appreciate it. Wonderful having you
My pleasure.
here. Yeah.